Thank you very much for this kind introduction. And I hope all of you are enjoying the meeting. It's been a pleasure to bring this meeting to all of you. Today I'm really going to dwell something different. I think Rajesh has done a great job of talking about how to manage patients in the hospital. And this was one of the things that we actually worked on. We brought out the inpatient guidelines from the RSSDI sometime 2 years back. And we thought that that was a big gap that we had, where people were not really getting to the targets within the hospital. And adverse outcomes were directly related to poor glycemic control. But even more than that is the fact that a large population of our patients in the outpatient setting needs insulin. And it's important for us to understand that when should we initiate the insulin, which insulin to choose, how do you titrate the insulin, when do you really go up on the dose, or when do you go down the dose, or what combination of insulins that you use. Life was a lot simpler when I was a resident and Madam Deote was my teacher. And at that point of time, she said, remember only 3 insulins. You've got animal insulins, that time we had the porcine and the bovine insulin. And she said, okay, remember regular insulin? You remember intermediate acting insulin, that we had the NPH that time. And we just had, I think, a premix insulin, yes. So we had to just choose between 3 insulins, and it was quite simple to do that. Now, over a period of time, we've had so many insulins come in, and now we are talking about design insulins. And over a period of time, in times to come, I just reviewed the entire literature of new insulins that are on the anvil, and you find there's so much of insulin that is going to come which has different modalities of action or different routes of action. And that's where, it's going to be a challenge to decide that which insulin are we really going to use. Question is, why or when do we really need to start the insulin? And this is going to be the outline of my talk. We're going to really set the scene that when do you really want to start insulin? Why is it so important to get your patients to control? And this data comes from various studies. We know that if you have 1% drop in the HbA1c, there is obviously reduction in terms of microvascular complications. Remember that tight, intensive control has direct impact more on microvascular complications than macrovascular complications. But there's clear evidence that it causes 21% reduction in diabetes-related deaths, 14% reduction in heart attacks, 37% reduction in microvascular disease, and 43% reduction in lower extremity amputation and fatal peripheral vascular disease, and 12% reduction in stroke. So this is no brainer as such. I think all of us read through various things. But it's really, the reality in India is that although the enhanced study, even in developed countries, showed that less than 50% of the patients were really achieving the target goals, the scenario in India is much more grimmer. If you look at what the DiabCare study showed, and this was done by a lot of stalwarts from India, including V. Mohan, Shashank Joshi, and so many other good people, we found that at an average, what are the goals that our patients achieve? And you find that in the population, our A1C goal average goal is 8.9%, random sugar is 193, fasting glucose is 147, post-meal is 205, and blood pressures are a little better. And only about 19.7% of our patients really get good glycemic control. So we really have a huge task ahead of us, that how can we really get to our patients better goals? And that's probably the centenary of insulin we are trying to celebrate, and see that even if we can reduce the national average of A1C by 1%, you're going to reduce the entire burden of complications to a large extent. So you may not really get them down to less than 7%, but even if you can bring them down from 8.9 to 7.9, just 1% drop, you're going to bring down a whole burden of complications across the country. And that's really the centenary goal that we're really looking at. Now, in our country, a little different approach is required, because if you look at the Western population, most of our guidelines say, fix the fasting first. And you say, okay, that is a good outlook, because if you get the fasting down, it's going to translate into better control throughout the day. But remember that the Western population has a very high amount of protein content in their diets as compared to what our diets, and that's a really carb-driven diets that we have got. So in our country, just looking at only the fasting glucose is really not enough. What you really also need to address is the post-meal sugars, because both of them drive the A1C up and the burden of complications. Now, as I just mentioned to you, this triad is all what we really sort of try to figure out, that can we attend the fasting glucose, can we address the postprandial, and in turn, can we bring the overall A1C drop? Now, earlier we had the concept of BIDS therapy where you have bedtime insulin and daytime sulfonylurea. And the idea was that, okay, if you can bring the fasting down, then maybe you're going to translate in the overall better control in the daytime. But that really does not mean that your post-meal glucoses are going to improve. You may get your fasting down, but you'll still have a residual post-meal burden, which we also need to address. So you have to titrate a basal to either basal plus or basal bolus, which means multiple insulinization. Now, remembering our patient population that we've got, it's very hard to convince our patients in the first place to take insulins. And if you tell them, take multiple shots of insulin, the cost and the inertia that the patient and the doctor both have to initiate the insulin becomes very high. So maybe if you have an easier solution as a compromise where we can use a premixed insulin, where you can address both the fasting and postprandial glucose control, it's going to be a better idea. Although we have seen comparative analysis of premixed and basal boluses, and you find that in terms of glycemic efficacy, both are very similar, although there is a slight increase in hypoglycemia rates with premixed as compared to the basal bolus regimes that you've got. Now, this is just a repetition of just what I've told you. And if you look at the comparative diets between the Indian population and the Western population, you can see clearly over here that the middle bar you can see is the carb. And you see whether it's a rural or urban, we still have a high carb. So there's more or less a lot of urbanization of the rural population that's happening. So although traditional diets were not really that carb-rich, we find that there's a lot of urbanization of the rural diets that have happened. And in them also we are seeing a lot of postprandial glucose elevations. Now this is a very good paper by Dr. Mohan and his group, and they looked at what was the vascular complications in the population, and they did the study over a 25 years duration. This was just a population-based study, and they found in about 726 South Indian population, which when studied over about 25 years duration, they had presence of retinopathy in about 52% of population. 41% had non-proliferative retinopathy. Nephropathy was present in 12%, neuropathy in 69%, and 32% had ischemic heart disease. Now, if you look at what are the variables that really drove the complication rates, one of the startling facts that really comes out is it's the postprandial glucose or postprandial hyperglycemia which really drives this to almost twice the, two times as much the population getting the occurrences of nephropathy, neuropathy, or retinopathy. So it's in our population, perhaps addressing the postprandial glucose becomes a very important concern other than the fasting plasma glucose. Look at the DECODE study. This was almost a population of more than 25,000 studied over a 10-year duration. And they looked at what parameter really drove the mortality. And they looked at fasting glucose, and they looked at post-meal glucose on an oral glucose tolerance test. And they found that while there was an increase in the fasting plasma glucose, the entire A1C and the mortality was driven more by the postprandial glucose, and the fasting glucose really was not much of a contributor in terms of mortality. Now, if you look at the percentage of people who are achieving, if I have to put my bet and say, should I really target my patient for fasting glucose or for a post-meal glucose, what am I going to address first? This was a very good statistics that really came out. And if you say target only the fasting plasma glucose, you'd probably achieve a fasting glucose of less than 100 when about 64% of population, the A1C of less than 7%. But if I target a post-meal glucose of less than 140, I would probably achieve in 94% of the population an A1C target of less than 7%. This is how we really have our patients who come to us in practice. At one end of the spectrum, you've got somebody who comes to us, let's say, with a presenting A1C of more than 9%, 9.5, 10, 11, 12%. And it's not uncommon that they may be completely asymptomatic. Having said this, when they come to us, our choice is should we put them on oral medication or on insulin as the starting point. Remember that most of the oral agents, whether used in combinations of 2 or 3, you achieve, depending of course on what your presenting A1C is, you do not achieve an A1C drop of more than 2 depending on, of course, what your presenting A1C is, because the higher the A1C, the more when you initiate treatment, the more A1C drop you tend to get. And that's what research really tells us about it all. But overall, combination of agents do not get you down by more than about 2% with oral agents. So if you've got somebody who's come to us with an A1C of, let's say, 12 and 13, unless you use insulin along with the OHAs, you will not bring them down to target. So you would have one set of population who presents to you with high A1C, or they may come to us with the critical illness. You may have somebody who comes to us with systemic infections or sepsis or an MI, and you know that this patient clearly needs an insulin at the point of presentation. You've got the other end of the spectrum where your patient has been for some time diabetic. You probably are looking at an OHA failure, and you've maxed the doses out to 2 agents or 3 agents. We are now reviewing the RSSGI guidelines. We just had a consensus meeting last weekend, and we're trying to review and present to you by in about 2 months' time what the national guidelines are going to be. And our recommendation is going to be that if you have 3 agents which you have maxed out in terms of dose, and of which one of the agent is a newer agent like an SGLT2 inhibitor, and you don't get to your targets, then likely that you need to move your patients to an insulin therapy. So this is what probably we're going to talk about in the new guidelines that are going to come in. Now, in between, you've got somebody who's probably euglycemic, but comes with a stress hyperglycemia. And if you have somebody who presents in the hospital with an acute critical illness and becomes hyperglycemic, may not have been a detected hyperglycemia, then this patient clearly needs to go onto insulin in the acute phase. Maybe at a later point of time, if he's got a good residual beta cell function, he may move back to either OHA or normal glycemia. But in the duration of the critical illness, you need to supplement insulin for the patient. Now, I'm going to review the data on what are your current insulins that are available in the market. Because why is this important? Because you've got a whole plethora of insulins, and all of them have a role to play, and you need to identify which insulin are you really going to use in your day-to-day practice. Because it doesn't get driven only by somebody coming and tell you, just use this, and you use it in all your patient population. You have got, of course, the basal insulins that we have. You've got a bolus insulins, and you've got a premixed insulin. Now, at the time of discovery of insulin, you had, of course, the Banting Best, and then you had the McLeod and Collops, who sat down, and, of course, we had the discovery of insulin. And we've walked a long journey. Till now, we've got ultra-long-acting insulins like degludec. What has been the pharmacokinetics about all these new insulins? You look at, of course, the duration of the action of the insulin. You want to see that how least glycemic variability that you can get with these new insulins. Why is it important? Because any complication is driven not only by the A1C that you have, but also is driven by how much glycemic variability a patient has during intraday or interday period. And if you can address this challenge of glycemic variability by your treatment, you're obviously going to add life to years and reduce the burden of complications. So if you'll walk this entire insulin overall, you find that your earlier insulin had the basal insulins had a half-life of about 5 to 10 hours, and now it's been driven by ultra-long-acting insulins, which has a half-life of almost about 25 hours. And if you look at the last line, you find the glycemic variability with just increasing the half-life has come down, and that probably added together adds to an advantage. So these are, of course, the pharmacokinetic and dynamic properties of all these individual agents. Remember that most of the earlier insulins, when you use it at a dose of less than 0.5 units per kilogram per day, have more or less uniform action. Their variability actually starts when you start using insulins beyond 0.5 units per kilogram per day, where most of the insulins will tend to peak and have a hypoglycemic effect. So if you look at NPH, you look at U100 glargine, you look at detamir, most of these will probably have very similar actions and the duration of action. But when you use it at higher doses, they will start peaking and give you a hypoglycemic response. The advantage of using degludec is it has the dose stabilization occurs about 72 hours later, and you get lesser amount of variability. And that's how probably the peaks are much lower and the hypoglycemias become less. You have a distinct advantage of using U300 over U100 is only in this population where you find that when you're using a large amount of insulin and you're using a concentrated insulin, the overall dose requirement tends to come down. But this is supplemented that you have to use the volume of the insulin comes down, but the dose has to be supplemented by 10% when you're switching from U100 to U300. But this is advantageous to use only when you have an evening hyperglycemia. So suppose you give a U300 or U100 to somebody in the bedtime, and you find that next day evening there is a hyperglycemic response the patient is getting. That's because of the peak and tailing effect. Now, if you get an evening hyperglycemia and you change from U100 to U300, there is a likelihood that you may offset this evening hyperglycemia in the patient. But degludec truly has a flat duration of action, and that really works very well even at high amounts of doses. So these are just the advantages and limitations that you've got of each of these insulins. If you ask me, where do I use these insulins? NPH is good. We still use it as a basal insulin, but you have to use it twice a day. And in cost limitation, where cost becomes a major factor to use, NPH really works as well. Glargine has a lot of trials to its credit, but of course you can use it morning or evening, or you can split the dose at higher amounts and you can use it. But the flexibility becomes an issue. And as I said, that you have a peak and tailing effect that happens with patients. Detimer, I would use in patients, obese patients, because it has a weight neutrality even at high amounts of dose that you give the patient. U300, I just told you, and degludec has an advantage that not only besides the flatness of its action, you can have the option of giving it at different times of the day. Because if suppose you've got somebody who's usually taking it at night time and he misses the night time, can he take it in the morning? Or if he's taking in the morning, can he take it in the evening? You have the option that he can shift the timings of injecting the basal insulin to himself. So if I have to sum up the advantages of basal and the disadvantages, the advantage, of course, that you can use it as a single agent, supplementing the oral agent. When you have that the OHs are not getting you to target, you can supplement it. And then, of course, if you still don't reach the target, you can intensify by adding a prandial insulin or moving them to premixed insulins. They cause less weight gain and hypos. And then, of course, you have to titrate them very effectively. It's very simple titration. Either you can increase by 1 unit every day or 2 units and keep monitoring the fasting glucose and then get them down to target, and then you can start looking at the daytime glucose levels. The disadvantage is, of course, that it may not achieve total glycemic control, so you may still end up using additional insulin during the daytime. And then, of course, you have to keep talking about the postprandial hypoglycemia with the patient to add other insulins. Now, what we are really interested in seeing in all these insulins is, are they really equipotent in the actions, or are there some differences that you've got? And this paper really looked at the glucose infusion rates and the amount of insulin that is there when they gave 0.4 units per kilogram, and they give over a 4-day period, and they looked at the coefficient variation. So this was done on a euglycemic clamp studies, and you found that the coefficient of variation was least with detimer as compared to either U100 or NPH insulins. Now, when you compare all the newer insulins against NPH in terms of the hypoglycemic occurrences, all the new analogs are perhaps better in terms of their action or occurrences of hypoglycemia rates when you compare them with NPH insulins. As I just talked to you about, I'm not going to repeat that again. You've got similar data when you compare U100 versus degludec in terms of the action profiles or occurrences of hypoglycemia. But look at these curves that you can see over here. You find that, as I just told you, that there is a peak effect that you get with U100 when you use it at a higher doses, whereas you get a more flat line or action even if it's given over a 24-hour period at higher doses. So you don't get that amount of variability, so the hypoglycemias tend to become less. What ultimately is degludec is, of course, they remove the threonine component from B3 and they add a fatty diacid side chain to increase the duration of action as such. Now, do we have hardcore data to say that this really works? And you have the Switch 2 trial, and what they did was they had 2 arms of the trial. One arm was given degludec once a day along or in absence of OADs, and the other arm got U100. And then after a period of 32 weeks, they were switched. So the arm with U100 got degludec, and the degludec arm got glargine. And if you look on the left side, that was the inclusion criteria, where you had patients more than 18 years who were type 2 diabetics for more than 26 weeks, has been on basal plus or minus OADs for more than 26 weeks and not achieved the targets, and they A1Cs in this population were looked at was less than 9.5%, and the BMIs were less than 45. What are the results showed? So while there was a good A1C control with both the arms, you found that if you look at the occurrences of hypoglycemia, whether it's severe hypoglycemia, overall symptomatic hypoglycemia, or nocturnal hypoglycemia, it was much lower with the degludec group as compared to the U100. Why are we really talking about hypoglycemias? I mean, whenever you have any therapy that we talk about when you control blood glucoses, two important concerns really that come to mind is hypoglycemia and weight gain. And perhaps, and of course, the A1C drop that we are really looking at. So anything that you're designing in terms of patients, you've got to address these three concerns very importantly. And of these three, hypoglycemia is the most important. You cannot drive an intensive regimen, push this patient to hypoglycemia, and risk him for brain damage or have a problem with their hands. So people have had in night asymptomatic hypoglycemia and ended up with brain problems in the morning. So they have hypoglycemic brain damages. So hypoglycemia becomes an important limiting factor in terms of intensifications of therapy. Now, if you were just to drop the A1C by 1%, what would be the percentage of hypoglycemia that these two arms would be seen? And you find that the hypoglycemia arm, the hypoglycemia with the degludec arm was much lower than the U100 arm when you drop the A1C by only 1%. Then, of course, came the DEVOTE study, which was a very good study that came out, I think, sometime last year or the year before that. And they looked at two arms. They looked at degludec once a day with standard of care against U100, very similar, and standard of care. And this was a 30-month trial. And what they found out, of course, this was seen in a CV risk population. So this was not really an asymptomatic population. These were patients who had a high CV risk. And they found that the time to occurrence of first adverse cardiac events were the same. But again, you had very similar results that you had much lower hypoglycemia. Now, if you have to look at a surrogate, the U100 has already been proved to be CV safe through the ORIGIN trial. And you were comparing the degludec against U100. So by surrogacy, you find that there's more or less CV safety of degludec that you've got. So if you have to sum up in the three trials, and you have to look at the evidence in more than 16,000 patients, you find that whether it's the BEGIN, SWITCH 2, or the DEVOTE trials, all three trials showed a much lower incidences of hypoglycemia, whether it's nocturnal or severe, in patients who are getting degludec. So if you have to review the ADA ESG guidelines and you have patients who have got established cardiovascular disease or CKD, your first choice, remember now we've got the pumps and the pipes theory. So if anybody who's got an atherothrombotic disease and you have to give a choice in terms of the CV risk reduction or event rates, your choice is GLP-1s. And if you're looking at patients with pump failures, your choice is always SGLT2 inhibitor. So that's now the current thought process, and that's what the ADA ESG guidelines also tell us, that if you have somebody with low ejection fraction, heart failure risk, you give them SGLT2 inhibitors. Anybody who's got a high risk of MI or stroke, your choice is, of course, much more skewed towards a GLP-1 analog. But when the combination of these two do not really work in terms of the glycemic control, what is going to be a next option? Your next option is going to be basal insulin, because if you've already exhausted the option of an incretin therapy, you don't combine two incretins together. So if you've given a GLP-1 analog as well as a SGLT2, you have to fall back on a basal insulin in this population of patients. Again, if hypoglycemia becomes a concern, you have to use agents which will have minimal effects or minimal side effects of hypoglycemia. And you again boil down to, after SGLT2 and GLP-1, to use basal insulins. Now, if weight is a concern, you have to judiciously use, and there are only two agents which really cause a weight reduction, and that's GLP-1 and SGLT2. And if you have to use another choice, then perhaps the complementary action of basal insulin along with GLP-1 works to your advantage. And then, of course, if cost is an issue, and we just had an excellent lecture by Vivian who talked about low-cost medications, is it still relevant in India? And the answer is yes. Patients do have, in terms of longevity of treatment, they look at costs as a concern. So you have, of course, the sulfonylureas, TZDs, and with the Carolina trial, the issues have come back into vogue. The TZDs, we just had a good lecture by Ken Kusi who talked about the use of pioglitazone. But then again, basal insulin still stays top of the charts because it's still affordable to use in our patients. Now, at some point of time, we do find that basal insulin may not be enough, and we still need to add a prandial insulin to the patient. And we have got a number of prandial insulins in the market. You've got, of course, fast-acting insulins, ultra-fast-acting insulins, and a number of others. So you've got the regular insulin, you've got the analog insulin, and now, of course, you've got the ultra-fast-acting insulins. All this basically is tailored to the fact that how quick you can get the initiation of action and what is the duration of action this has. So if you look at the regular insulin, it takes about 2 hours for the initiation of action, peaks at about 4, and the duration of action is about 6 to 8 hours. Whereas if you look at the ultra-fast-acting insulin, on the other hand, the initiation of action is in about 10 minutes or 15 minutes duration, and it's over in about 2 to 4 hours, with a peaking effect in about 1 to 2 hours. So you've got so much of this. So where would you really put an ultra-fast-acting insulin? When you want an immediate postprandial control, and where you find that you don't have the timing of the meal really standardized. So you can either inject and eat or eat and inject. And you can inject even 20 minutes after the initiation of meal, which will still be good enough for the patient. Remember, although we say that the analog insulin should be given immediately before, you still need to give it about 10 to 15 minutes before the meal. So that really works to your advantage to use. Also, because of the shorter duration of action of ultra-fast or the analog insulins, where you find that the degradation or the action of the insulin is going to be prolonged and hypoglycemia is going to be a concern, like patients with acute kidney disease or chronic kidney disease where the excretion is going to be delayed, you find that using these insulins with a shorter duration of action may be advantageous. So these are all the things that require. What are the advantages? Again, you have flexibility with the basal boluses. You've got better metabolic. It mimics a normal sort of physiology of insulin secretion. The disadvantages, of course, you've got multiple insulins that you need to give the patient, and yet hypoglycemia and weight may be a concern for you. I'm going to come to the last part of my talk in the last 3 minutes that I've got, and that is use of premixed insulin, because that is a huge amount of area that I think all of us need. We give premix to our patients. It's been always a concern that which premix that we need to give. We've got 30-70, we've got 50-50, we've got, again, so many other analogs, and then we've got, of course, the degludec and the insulin co-formulation, insulin aspart co-formulations. This is all with the aim, as I told you earlier, that you want to address both the fasting and post-meal sugars. And if you are looking at something to reduce the burden of insulin injections, then perhaps your new desired insulin of degludec and aspart comes to your rescue, where they have a better control of both the arms. You can probably, if you find that there's a postprandial, both the fasting and post-meal is high, with the highest meal, which gives the glycemic excursion, you can give this co-formulation. So that will probably help the meal surge of glucose that you've got, and it will also act as a basal throughout the day. So it gives you a little flexibility of dosing to decide which meal should be given the co-formulation. This is again the advantages and disadvantages. It's relatively easy and simple to teach the patient. It offers good fasting and post-meal control. It's effective in lowering the A1C, and you get better compliance with the patient. The disadvantage, of course, that it's a little rigid in terms of its use. I've always been asked this question that where can I use a 30-70 and where can I use a 50-50? And that's always been in the top of the minds, that is it really interchangeable? And the answer is no. If you remember that 30 and 70, 30 is short acting and 70 is intermediate acting. So if you find that the pre-dinner is a concern and you need to control pre-dinner hyperglycemia, you need more of intermediate acting insulins. And that's where probably a 30-70 comes to your rescue. But from this talk, don't delay in insulin initiation, titration, and intensification. Don't procrastinate. You have to timely start the insulin and act on intensification. Manage both the fasting and postprandial hyperglycemia, and begin with the end in mind as such. You've got the basal insulins. You decide where you need to use it. You know that when you need intensification, basal bolus is the way to go. And somewhere in between, you've got a population which needs the premix formulation. So treatment approach should be good, and early glycemic control should be the aim. You have OADs which are useful in the management of type 2 diabetes, but insulin offers the maximum glycemic control. And then, of course, you've got the evidence and recommendations from guidelines across the world which recommend that timely insulin therapy for better glycemic control is the way to go. Thank you very much for your patient hearing.